Okay, hi everybody. It gives me great pleasure to welcome you all to our jointly developed webinar about epilepsy for colleagues from primary care. Thank you so much for joining us for this session. I'm going to lead off straight away because we've got an exciting but very full agenda. Just to advise, the session will be recorded to enable us to make this available on Healthier Together following the event. Few points of housekeeping, if I may. Please can participants stay on mute throughout the session unless you're actively taking part in discussion. We're a sizable group and this will help with bandwidth. Can we ask participants not to take control of the slides or attempt to move them along? We will, of course, share all the resources and the slides widely following the event, and we'll collate all the questions that have been asked and the answers that have been given for wider sharing. Please can we ask participants to introduce themselves in the chat and identify their practice, PCN and geography that they represent so that we can get an understanding of reach for our session. Do feel free to use the chat facility throughout, and please note that we will be sharing this recording and the details of the discussions. So this is just a polite reminder to remind participants about confidentiality when discussing practical application. We have expert colleagues here tonight who will be responding to the chat facility throughout, and anything that we cannot respond to from an adults or neurology perspective, we will follow up and include within the resources. By way of introduction then, my name is Louise Dauncey and I'm a Network Delivery Manager for the Child Health and Wellbeing Network, and my main role and responsibility is around the delivery of the Children and Young Persons Transformation Agenda here in the North East and North Cumbria. I'm here on behalf of the Child Health and Wellbeing Network and the North East North Cumbria ICS Epilepsy Leadership Group, and I'm delighted to be here alongside my colleague Emma from the North East North Cumbria Learning Disability Network, who will provide a brief introduction shortly. Next slide, please. So I appreciate there's a lot on this slide here, so this is just to give a sense of what we're planning to cover tonight. There will be some introductory slides followed by the main education event regarding epilepsy. Next slide, please. I won't go into detail on this slide, but this is just to provide local context about our local population and also to give an indication of the size of our geography. The map here shows the 4 area ICPs and marks out the 13 local authority boundary areas, and within this you'll appreciate it includes 13 local authorities, 13 local education authorities, 13 public health authorities, 8 acute trusts, 3 ambulance services and numerous PCNs. We operate across a wide geography and diverse population with wide-ranging socioeconomic challenges. Next slide, please. I won't labour this slide, but this is just really to set the scene and highlight the local levels of relative poverty and our challenges here in the North East and North Cumbria. As a professional working in this area, I'm sure you'll be well versed and well aware of the socioeconomic challenges that we have locally and the impact of this on health and other outcomes for our populations at large. Highlighted here are the highest levels of poverty in England and some of the suggested ways that we're seeking to overcome these challenges, including collaborative work across the system and targeting our resources to upskill frontline workforce. Next slide, please. So the North East North Cumbria Child Health and Wellbeing Network has a series of priorities that have been determined by initial consultation. They're identified here on the wheel on the left-hand side. These areas won't be a surprise to colleagues given what we know about the levels of deprivation in our area. Within these priorities, the Child Health and Wellbeing Network has a growing role in relation to the Children and Young Persons Transformation Agenda, particularly with respect to additional needs, vulnerability and childhood illness. We in the network have an overriding vision which holds children at the centre of all we do, and the mission statement outlines our belief that children should be given opportunities and that this should be enabled by the system-wide partners working cohesively. Our role is about sharing good practice and driving improvement and enabling those platforms for connection. We have a network which is broad and is growing, currently stands at about 2,000 members, and there's a link there to join if you are interested in hearing more about the work that we do. Within the network, we have a broad range of programmes including Youth Voice, Healthcare Inequalities and Core 20, Communications and Engagement, Children and Young Persons Integration, and also the delivery of the Children and Young Persons Transformation Programme. I'm going to hand now to Emma, who'll briefly introduce herself and the North East North Cumbria Learning Disability Network.
Good evening, my name's Emma Cheetham. I work for the North Eastern Cumbria Learning Disability Network. So we sit within North East North Cumbria ICB, and I believe that we're the only learning disability network within an ICB, so we're quite unique to North East North Cumbria. The vision of the network is that it'll be the best place in England to live if you have a learning disability and or autism. And our mission is to tackle health and social care inequalities faced by people with a learning disability and or autistic people. What we know, people with learning disabilities die approximately 22 years younger than people without, and the health inequality gap is huge. Our values are that people with a learning disability and or autistic people and their families will be at the centre of all the work that we do. Next slide, please. So we work across health and social care, community voluntary sector, education, multi-stakeholder network working, tackling health inequalities and working collaboratively, work innovatively, creatively, thinking about how to improve people's lives. Specifically, epilepsy today, it's a priority in terms of my work programme, because I do physical health and long-term conditions, because if you have a learning disability, you're actually 22 times more likely to have epilepsy. So thank you for all coming today to learn a little bit more. Thank you. Next slide.
Great, thanks, Emma. That's really helpful context to set the scene around our work. So in relation to the North East North Cumbria Paediatric Epilepsy Leadership Group, we are a small team who've worked together since 2021, and we've delivered a whole programme of work which has been associated with paediatric epilepsy. A few examples include the establishment of a multi-agency alliance group, a series of quality improvement projects within paediatric epilepsy. We're working with colleagues in services to increase clinical capacity, and we've also worked with the RCPCH recently to deliver an interactive innovation lab day, which was involving young people in service improvement and service design. And more recently, we've been working with colleagues from the Learning Disabilities Network, and we're taking a collaborative approach to supporting transition for epilepsy patients from paediatric healthcare services to adult healthcare services. So in May, we collaboratively delivered a face-to-face secondary care education session, which focused on transition for our epilepsy patients. So the Paediatric Epilepsy Bundle was released in October 23, and we're undertaking a whole raft of work around localised service improvement. Dr. Kumar is the North East North Cumbria Clinical Lead for Paediatric Epilepsy. Dr. Jayachandran is the Chair for PENEC, which is the Paediatric Epilepsy Network for the North East and North Cumbria. And Sophie Gilmore-Ivans, who we'll hear from tonight, is our Regional Strategic Paediatric ESN Lead. Dr. Kumar, Sophie, Emma and I are joined by Sarah Bennison and Amanda Boardman for this session, all of whom will be available within the chat and will be responding to questions from participants during the session, and obviously at the end for any questions that people may have. We're also really lucky to be joined by Leah Norton from Epilepsy Action, who will say a few words about the available resources and will be available as part of the chat to support with responses. I'll hand now to Dr. Boardman, who'll say a few words of introduction. Thank you.
Thanks, Louise. So yeah, I suppose that why am I here today? So I was asked just to kind of give a brief introduction as to why it is that I feel it's so important for doctors and nurses in primary care to get training around epilepsy. So I've been a GP in Cumbria for nearly 30 years now, but when I think back over my medical career, I've had very limited training on epilepsy. And yet, what do the stats tell us about our practice populations? So 1 in 100 people on your GP practice list will have epilepsy. Only 52% of those people will be seizure-free. There are 21 epilepsy-related deaths per week in the UK. 1 in 3 people with epilepsy will suffer with depression versus 1 in 6 of the general population. So what those stats tell me as a clinician is that epilepsy has a significant impact on both the physical and mental health of our patients. Lots of our medications that we use have significant side effects, including drowsiness and cognitive problems. Epilepsy has significant restrictions on everyday living, resulting in reduced quality of life. And there's always an ongoing fear of seizures, so leading to anxiety about even getting outside the door. And don't forget about the impact on family and carers as well. One of the main reasons why I'm here tonight is that 14th of October is the 8th anniversary of my son's diagnosis. So I am a parent carer, and that is when my epilepsy education really started. Watching someone that you care for and love having a grand mal seizure is one of the most terrifying things. Even though I'm a doctor, it is still leaves a huge scar on my life. And even though it's been 6 months since his last seizure, I have a panic attack whenever I see or hear a blue light ambulance and he is not with me. So I'm just really thankful to the Children's Network for putting on this training tonight. I hope you'll find it useful. And I'm especially thankful to Leah and Epilepsy Action for all the work that you're doing nationally to raise the profile of epilepsy on behalf of all of those affected by it. Thank you. Leah, I'm handing over to you, I think.
Thank you very much. I was just going to say, I think that leads nicely into me. Thank you very much, Mandy. And thank you very much, everybody, for having us here today. As people have said, I'm here from Epilepsy Action. If you've never heard of us before, we're a nationwide charity. Next slide, please. So who are Epilepsy Action? If you haven't heard of us before, we are one of the leading epilepsy charities within the UK. We're a UK-wide charity, and we work to support the 630,000 people that are living with epilepsy in the UK. But actually broader than that, and I think really ties into what Mandy's just said there, is that we're not just here for the people living themselves with epilepsy. We're here for everybody that is affected by an epilepsy diagnosis. So that is family, it's friends, it's partners, it's children. It's a huge breadth of people that are affected when someone gets a diagnosis. Our ambitions, and this all ties into our brand new strategy that came out this year, are to improve the lives of everyone with epilepsy and everybody that's affected by epilepsy as well. To raise public understanding of epilepsy, so that's to ensure every healthcare professional understands epilepsy, to ensure that if someone had a seizure on the street, people would know exactly what to do immediately. That's all kind of wrapped up within that. And also to be fully inclusive of everybody. Next slide, please. We have a huge breadth of work within Epilepsy Action, and we're possibly a smaller charity than you might expect. We've got less than 100 members of staff, and we're a nationwide charity. So I'm doing a very much a whistle-stop tour, but I can answer any questions in the chat and I can send in links if people need them. I wanted to highlight the resources that are available for yourselves. So as healthcare professionals within primary care. So one of the first things is a free training module for primary care nurses. So this goes through different seizure types, what to do when someone has a seizure, bits on medication. It's a really, really in-depth course and it's completely free. So although you're going to be getting a really good education this evening, if you want to go on and do further, this is a really great course for you. We have, again, completely free templates of care plans and seizure diaries. These are absolutely fundamental in the care of a person with epilepsy, and also make things easier for you as well. If you have a seizure diary that's telling you exactly how many seizures somebody's having, it's so much easier to control their condition and work with them to get to that kind of seizure free, which everybody is aiming for. We have a drug watch page, which tells you all about which medicine shortages are happening at the moment, and when when we've been told that they will be back in stock, which again is a really helpful resource if you have someone in front of you asking for a certain medicine and you're not able to get it. We have loads of printable health information that covers everything that you might get asked. So driving, drinking alcohol, if it's younger people, not children, younger people, then things about getting pregnant, about the preconception counselling, all of these really, really important things that you may be asked. And obviously you can't be experts on everything, but that's where we're hoping to fill some of that gap. We have resources that are available to order. So we have different booklets, we have seizure alert cards that people can put in lanyards so people know again what to do should they need them. And we have advice for professionals available through our helpline. So you can ring our helpline as a healthcare professional. Again, if there's a question you've been asked you don't know the answer to, for advice, whatever it is that you need. Next slide, please. And then my final slide, a nice whistle-stop tour, as I said, is what you can tell your patients that they can access through us. So huge amounts of information on our website. Again, this covers pregnancy, it covers newly diagnosed people that have had a change, withdrawing from medication, loads and loads of different things. We have our helpline. This is available, either people can ring or they can chat to them on live chat, which is a really popular second option. Again, particularly I think with young people and those that are newly diagnosed, it's, well, you know what young people can be like, phones and things. It's just a different way of being able to talk to somebody without having to pick up the phone and make that call. We have two different kinds of talk and support groups. So we have an online groups and in-person groups. So you can advise people to come along to those. They're really fantastic groups and make a real difference to people's lives. They're all over the age of 18 for all our services apart from the helpline. So do just bear this in mind. And there are other charities that can fill the gap kind of where we don't. We have a befriending service. So this is a weekly call for 12 weeks. And again, is making such an important difference to people's lives. Just being able to talk to somebody else who has experience with epilepsy, for people, particularly those in kind of really remote areas where they might not have met people that have epilepsy before, can just make people feel so much less isolated. There's free online training for people with epilepsy and their carers. There's also schools courses. So yeah, real breadth of kind of training out there for people. We do have children's resources. So we've got books. We're actually heading to the New Scientist Live exhibition in London this weekend. So we're taking lots of books to that. So we have lots of children and young people resources as well. And support for parents and carers, which, as we kind of have already talked about, is so important. And that is everything from me. So thank you again so much for having us. We're really privileged to be working with lots of people on this call on different projects. And yeah, it's all really important work. So massive thank you. And I believe I'm passing over to Sophie. Thank you.
Thank you, Leah. My name's Sophie Gilmore-Ivans. I'm one of the paediatric epilepsy specialist nurses at Northumbria Healthcare, but at the moment I'm also seconded into post as the paediatric epilepsy specialist nurse strategic lead, which is a bit of a mouthful, but essentially I'm got a region-wide post looking at ways in which we can improve the care and the lives of children and young people with epilepsy in the North East and North Cumbria. Next slide, please. So I'm going to start with a question, and this is going back to basics for a lot of you, I imagine. But what is epilepsy? It's a condition defined by a person having at least 2 unprovoked seizures occurring more than 24 hours apart, the probability of further seizures occurring over the next 10 years, and/or a diagnosis of an epilepsy syndrome. And when we think about the UK population as a whole, approximately 1 in 100 people has epilepsy, and 1 in 200 school-aged children also has a diagnosis. I've put the epilepsies in brackets because of the diversity of types and causes, and the fact that we need to remember that it's not a single condition. Next slide, please. So this slide shows an overview of how we think about epilepsy, the causes, the different ways we classify seizures, and the potential comorbidities that are associated with epilepsy. And I'm going to expand upon these in the next few slides. So next slide, please. When we think about what causes epilepsy, anything that alters the structure of the brain, whether it's developmental or acquired, can give rise to seizures. We know that some epilepsy syndromes are caused by mutations in a single gene. So mutations in SCN1A and SCN1B cause Dravet syndrome and genetic epilepsy with febrile seizures plus. And mutations in PCDH19 are associated with epilepsy predominantly in females who can have multiple seizure types. There can be associated intellectual disability, psychiatric comorbidities, and some of these women and girls will have ictal apnea. Whereas the genetic generalized epilepsies, like childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone, are thought to have a polygenic basis. But there's ongoing research that suggests that single genes could be implicated in some of the GGEs, such as SLC2A1, which causes GLUT1 transporter deficiency, but may also have a role to play in juvenile absence epilepsy. Infection is probably the leading cause of epilepsy worldwide and is the most common cause in the developing world, where infections like malaria and TB are more common. GLUT1 is an inborn error of metabolism which causes epilepsy, and seizures can also be caused by acquired metabolic issues such as severe vitamin B12 deficiency. Autoimmune epilepsy is caused by a change in the body's immune function, and this could be due to autoimmune encephalitis or other autoimmune conditions such as lupus or Crohn's disease. There are neurodegenerative conditions like Batten disease, which is an umbrella term for several different genetic life-limiting diseases that share similar features, and Alpers-Huttenlocher syndrome, which is caused by mutations in the POLG gene, and they both have epilepsy as part of them. And epilepsies where no cause can be found fall into the unknown category. Next slide, please. So again, going back to basics, what is an epileptic seizure? It's a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And seizures can manifest as a disturbance of consciousness, behavior, cognition, emotion, motor function, or sensation. I like these definitions as they capture the entirety of the breadth of seizure presentations, and you might be surprised to learn that there are over 60 different types of seizures. Next slide, please. Epileptic seizures are categorized by where in the brain they start, and they can be described as focal, generalized, or for seizures with inadequate information or an inability to place elsewhere, there's an unknown onset category. Next slide, please. So focal seizures are seizures that start in one lobe of the brain. Because each part of the brain is responsible for a different function, how the seizure presents will depend upon which part of the brain it starts in. For example, the occipital lobe at the back of the brain is responsible for vision. Therefore, if you have a focal seizure in that area, you may see flashing lights, colours, or simple patterns, but you could also have temporary loss of vision. Motor features are prominent with frontal lobe seizures, so you may see a fencing posture, pelvic thrusting, kicking or pedaling, head and eye deviation, but there can also be screaming, swearing, or laughing. Parietal lobe seizures involve sensation, and this could be paresthesia or numbness, and less commonly pain and thermal perception change. And temporal lobe seizures, which are the most commonly seen focal seizures, can involve symptoms like déjà vu, auditory or olfactory hallucinations, a churning or rising feeling in the stomach, or repeated swallowing or chewing. We try to say what we see with seizures. Therefore, focal seizures are either described as focal aware seizures, where there's no change in the person's awareness, or focal impaired awareness seizures, where, as the name suggests, there's a change in the person's level of awareness. They might be able to hear you but not fully understand what you're saying, and they may not be able to respond to you. We usually expect with these type of seizures, the person having it would not react as they would normally. We also describe focal seizures as motor or non-motor seizures. Motor seizures, as the name suggests, are seizures involving movements such as jerking or repeated movements like lip smacking, swallowing, or picking movements. Focal non-motor seizures are when the main symptoms don't involve the muscles. They can include things like changes in emotion, thinking, and sensations. And some examples of this would be experiencing déjà vu or jamais vu, which is when the person having the seizure doesn't recognise something or someone that should be familiar to them. A sudden intense feeling of panic, fear, or joy. A feeling of numbness or tingling. As I mentioned before, seizures from the parietal lobe often result in this kind of sensation seizures. And what happens will depend upon which area of which lobe of the brain the seizure has occurred in. Next slide, please. When someone has a focal seizure and the seizure activity does not remain confined to the lobe in which it starts, but spreads to bilateral cerebral networks, this is known as a focal to bilateral tonic-clonic seizure. Sometimes the spread in brain networks may be so rapid that no preceding focal seizure type is identified, and the child could be admitted to hospital with what is thought to be a generalised seizure, but has actually been a seizure with focal onset, and this requires careful history taking, as the type of epilepsy may influence which medications are used and which should be avoided, as some anti-seizure medications can exacerbate some types of seizures. Next slide, please. Generalized seizures affect both cerebral hemispheres, or the majority of both cerebral hemispheres from the beginning, and consciousness is always lost, albeit briefly, for some seizures. The generalized seizures are tonic, atonic, myoclonic, tonic-clonic, and absent seizures. And again, we try to say what we see. So atonic seizures are seizures without tone, and someone may fall limply to the ground like a puppet with the strings cut. Tonic seizures are stiff seizures. Tonic-clonic seizures are seizures where there is stiffness followed by jerking. Myoclonic seizures, myo means muscle and clonic means jerking. So these are seizures involving muscle jerks. They can affect a single hand or foot, or the head, or one half of the body, or sometimes they affect the whole body and the child or young person will fall to the floor. Absent seizures are the most common seizures that we see in primary age school children, and this is when the child has a behavioural arrest and looks like they are blank for a short period of time, and although their eyes are open, they are not conscious or aware of what's happening around them. There are typical absent seizures. The child suddenly stops and stares into space. They don't respond to people around them. Their eyelids may flutter. There could be slight jerking movements of their body or limbs. You may see automatisms, which are repetitive, purposeless movements. These absent seizures last approximately 5 to 20 seconds, and they can occur in clusters. In an atypical absent seizure, they last longer, so perhaps 20 to 30 seconds. They start and end more slowly. They can involve change of tone, and the young person may be able to respond during the event, but this isn't a normal response. I know I have one of my patients who, at the end of her absent seizure, her atypical absent seizure, she says, "I'm sorry, I'm sorry, I'm sorry," and then she comes out of it. So as she's coming to the end, there is obviously some change in her level of awareness, but she's still not aware. And afterwards, she cannot tell you that she's said those words. We also classify generalized seizures as being motor or non-motor seizures, and all the generalized seizures are motor seizures apart from absent seizures. Next slide, please. This is not an exhaustive list of triggers or provoking factors, but these are some of the more common ones. The ones I probably see in my practice most commonly are illness, with or without a temperature, and lack of sleep or disrupted sleep. In females, menstruation can be a trigger, so even if their seizure control is good for the rest of the month, the hormonal changes associated with their periods can trigger seizures. And this is usually in the 2 to 3 days before the period starts, or in the first 2 or 3 days of menstruation itself. And sometimes girls and women can have seizures around the time of ovulation. We sometimes use short courses of clobazam each month to try and manage what we call catamenial epilepsy. If people aren't taking their medication properly, this can cause seizures. Most anti-seizure medications are given twice a day, every day, as close to 12 hours apart as possible. Missed doses or where there is no routine for taking medication increases the likelihood of seizures. I've put flashing lights and photosensitivity on the list, as there's a common misconception that everyone with epilepsy is photosensitive. However, it is around 3 to 4% of people with epilepsy. And it's not just lights that affect those people who are photosensitive. Seizures can also be triggered by high contrasting patterns, such as stripes or bars with contrasts of light and dark. And these patterns are more likely to trigger a seizure if they're changing direction or flashing, rather than if they are still or moving slowly in one direction. Things that have been reported to me as being triggers are sunlight through slatted blinds, or through the trees when you're driving down a tree-lined street, or sunlight reflecting off the waves at the beach, or light moving through a moving ceiling fan. Similarly, an animated background on a Zoom or Teams call or a moving escalator can trigger a seizure. And when these seizures are triggered, it could be any type of seizure, but tonic-clonic seizures are the most common. Next slide, please. Most anti-seizure medications are prescribed in milligrams per kilogram per day in children, and each medication will have a range of milligrams per kilogram doses that are thought to be effective. As a general rule, starting low and increasing the dose slowly is the best way to avoid adverse effects, but this isn't always possible if you have a patient with regular seizures and you want to get them to a therapeutic dose as soon as possible. However, you can always slow down the titration regimen so that you're increasing doses less regularly than recommended in the BNF, and sometimes you do need to do this if the young person is struggling with side effects. In my experience, my patients do report side effects, but the majority of them settle after 10 to 14 days on a steady dose. So even when we're increasing the dose every 2 weeks and they experience side effects repeatedly during this period, once they reach the dose we're aiming for, things tend to settle down. Obviously, if they have intolerable side effects like self-injurious behaviours or suicidality, then we have to stop the anti-seizure medication and try something different. For example, if we see intolerable mood or behaviour side effects from levetiracetam, our first kind of choice would be to switch them to brivaracetam, which is an analogue of levetiracetam with fewer mood and behaviour effects. Most of the anti-seizure medications come in a variety of forms: liquids, tablets, dispersible tablets and sprinkles, and some of the medications come in more than one brand of liquid. So if I have a patient who can't swallow tablets but they won't take the Tegretol brand of carbamazepine liquid because they don't like the caramel flavour, I'll probably switch them to Sun carbamazepine as its orange flavour. As carbamazepine is a category 1 anti-seizure medication, you're supposed to ensure the patient is maintained on a specific manufacturer's product. However, if they won't take Tegretol at all, that poses more risk than switching them to another product that they will take and then maintain them on the new product. Another option for people who won't take liquid but can't swallow tablets are the sprinkles. Sodium valproate, topiramate and levetiracetam all come as sprinkles, which can be given on 1 spoonful of a cold, soft food like yogurt or sometimes Nutella, unless somebody's got a nut allergy. But in my experience, some neurodivergent young people don't like the texture of the sprinkles, so will refuse or spit them out. It's also worth knowing for people who wear pads that the shell of the sprinkles can appear in their stool once the active ingredient has been absorbed. But I've had a few concerned parents ring me as they've been worried that the medication has gone straight through their child, but this isn't the case. If you're going to prescribe lamotrigine, you need to think about whether the patient is on any other anti-seizure medications, as the prescribing advice in the BNF depends upon whether it's monotherapy, is being prescribed with sodium valproate, or with an enzyme inducer, or with another anti-seizure medication which isn't sodium valproate or an enzyme inducer. I want to talk about sodium valproate and topiramate because these are the 2 anti-seizure medications that are currently known to be more teratogenic than most of the others, and they are subject to specific advice from the MHRA. 1 in 9 babies born to females taking valproate will have a congenital malformation, such as a neural tube defect, malformation of limbs, heart, kidney, urinary tract, or genitalia. And 3 to 4 babies will have a developmental disorder like autism, ADHD, speech and language issues, or a lower IQ than their peers. Sodium valproate is thought to cause infertility in some males, and this may be reversible once valproate is stopped. One study that's currently being re-reviewed by the MHRA said that 5 out of 100 babies conceived when males are taking sodium valproate or within 3 months of stopping sodium valproate are at risk of developmental disorders. Therefore, there is a pregnancy prevention programme for females of childbearing potential and forms for both males and females up to the age of 55 that must be completed when valproate is started, and yearly for all females. It's a similar picture for females on topiramate, but this guidance is newer. The risks again are congenital malformations, neurodevelopmental disorders like autism and ADHD, and there's also a risk of babies being small for gestational age and lower birth weight. The risk of congenital malformations with topiramate appears to be dose dependent. However, a threshold dose below which no risk exists has not been established. Again, there's a pregnancy prevention programme and a risk acknowledgement form to complete annually for females. Next slide, please. Some other things to remember about anti-seizure medications are that during pregnancy, the plasma concentration of lamotrigine and phenytoin can fall, and this could increase the possibility of seizures. Erythromycin and grapefruit products increase the concentration of carbamazepine so that the patient may experience symptoms of carbamazepine toxicity like dizziness, somnolence, and falls. And the grapefruit interaction is also an issue with diazepam and midazolam. If you have a patient on an antihistamine like chlorpheniramine or cetirizine, or they are buying products over the counter and they're diagnosed with epilepsy, the advice is to switch their antihistamine to loratadine or desloratadine, as they are non-sedating and don't have epilepsy as a caution. There's some Korean research published in the Journal of American Medical Association in June 2024 that found an association between first-generation H1 antihistamines, including chlorpheniramine, and an increased risk of seizures in children, of which the risk was highest in the 6 to 24-month age group. Carbamazepine, phenobarbital, phenytoin, primidone, and sodium valproate are all known to carry the risk of osteoporosis. And the Royal Osteoporosis Society says that there is only limited and conflicting research data from studies of newer non-enzyme inducing anti-seizure medications like gabapentin, lamotrigine, topiramate, and levetiracetam regarding their effects on bone. But these studies do suggest that most anti-seizure medications are associated with a risk of fractures. The current UK guidance suggests considering vitamin D supplementation in people who are taking sodium valproate or any of the enzyme-inducing anti-epileptic drugs on a long-term basis, and those who are felt to be at higher risk. So this might be non-ambulant wheelchair users, people whose diets are deficient in calcium, or who have insufficient exposure to sunlight to maintain adequate vitamin D levels. Next slide, please. I get a lot of questions from my patients and other health professionals about contraception and anti-seizure medications because it isn't straightforward. If you're a female who's on sodium valproate, the MHRA recommends using at least one effective method of contraception, preferably a highly effective, user-independent form, such as an intrauterine device or an implant, or 2 complementary forms of contraception, including a barrier method, should be used. The enzyme-inducing anti-seizure medications and lamotrigine affect the efficacy of the hormonal contraceptive pills, the implant, the patch, the vaginal ring, and emergency contraception, but intrauterine devices and the contraception injection can be used. Lamotrigine is a bit special in that it's not an enzyme-inducing anti-seizure medication, but it affects the efficacy of all the contraceptive choices that the enzyme inducers do. And in addition to this, the combined pill can reduce the level of lamotrigine, making it more likely that the patient could have a seizure. And the progesterone-only pill increases the level of lamotrigine in the blood and could lead to toxicity. So if you're on lamotrigine, your contraceptive options are an intrauterine device, the contraceptive injection, and barrier methods, or sterilisation, but I never suggest this as I work in paediatrics. I'm now going to hand you over to my colleague Sarah, who will discuss non-medicine treatments for epilepsy, safety, SUDEP, and transition.
Hi, thanks, Sophie. My name's Sarah. I'm a paediatric epilepsy specialist nurse. As Sophie explained before, we have tried to keep this quite generic, but apologies if some of it does tend to lead more towards paediatrics. So if we first look at the ketogenic diet, this is a diet that is high in fat with adequate protein, low in carbohydrates. It was first described in medical literature in 1921 as a treatment for epilepsy in children. Sorry, this slide's just gone, 1 second. And this was following reports of the beneficial effects of fasting on seizure control. It's designed to mimic the metabolic changes that occur in the body during starvation, such as the adaptation to spare muscle protein breakdown and draw on energy reserves of body fat. The diet is undertaken by a team within the RVI, and the lead on that is Dr. Anita Devlin, and the specialist nurse is Lucy Bellis. The classic ketogenic diet is based on a ratio of fat to carbohydrate and protein, and it's a ratio of at least 3:1. It is usually needed for maintenance of a good state of ketosis and optimal seizure control. The MCT diet was developed in the 1970s as an alternative to the classical diet because MCT is absorbed and transported more efficiently in the body. There is less total fat needed, which allows more protein and carbohydrates to be included. The modified Atkins diet and low glycemic index diet are modified ketogenic diets which follow similar principles to the classical and MCT diets in that they are very low in carbohydrate and high in fat, but they also allow more flexibility of meal choice due to the main focus being around carbohydrate counting alongside portion guidance to ensure adequate calories from fats. Within the ketogenic diet, it is done over 2 years. However, due to the complexity of cooking separate meals, the team do advise families to batch cook. One of the other treatment options is the VNS, which stands for vagus nerve stimulation. There are 3 modes within this: the normal mode, magnet mode, and auto-stimulation mode. A vagal nerve stimulator is an implantable device that sits in the left side of the chest, just below the collarbone, and it has leads that come out and connect to the left side of the neck where the vagus nerve sits. The normal mode has a programmed duty cycle of off and on times, which sends electrical pulses to the vagus nerve at regular intervals. And this is all day, every day. These pulses are then carried by the vagus nerve to the brain, and a precise mechanism of action is still inconclusive. However, it is known to decrease frequency of chronic seizures. It can reduce the severity as well. There is a magnet mode, and this is activated by a special VNS magnet, which actually looks a bit like one of the smartwatches and is worn by the parent, carer, whoever is with the child or young person at the time. And this can be used before a seizure, during a seizure, or after a seizure to prevent further seizures. And it initiates an extra dose of stimulation, and it's usually longer and at a higher output than the current output from a normal mode. And this is used to try and terminate seizures. The auto-stimulation mode, which is a feature of VNS models since 2015, works by monitoring baseline heart rates, and in response to a pre-programmed percentage rise in heart rate within 2 seconds. This is usually associated with the start of a seizure. At this point, the device gives an additional stimulation, like a magnet stimulation, which tries to terminate the seizure as well. When considering epilepsy, whether it is within children or adults, it's important to look at the safety advice we give. So we look at it in a few different sections. One of it is with heat. So we have to be careful around things such as hot radiators, fires, kettles, so even making a hot drink, ovens, hobs and hair straighteners. With things such as ovens, we actually recommend that people with epilepsy don't lift hot dishes out of the oven, and certainly as adults living independently, don't lift them far across the kitchen. When you're looking at heights, we actually advise for people with epilepsy not to do heights that are unharnessed, such as free climbing, up trees or up climbing frames. However, if it's an activity such as, for example, through school or college, where they have safety equipment such as helmets or safety harnesses, this is allowed, assuming their seizures are well controlled. We then look at traffic, so we advise for them not to cycle on the roads, and they cannot do go-karting, quad biking or drive a vehicle until they have been seizure-free for 1 year. When we look at water safety, we actually advise for them to shower in preference of bath. This is because with showers, the water drains away freely, preventing the risk of the head going underwater and drowning. We actually advise for them not to go swimming or do water sports in open water until they've been seizure-free for at least a year. With regards to pool swimming, they can go pool swimming, but they should have appropriate one-to-one supervision. If we continue along the safety line, one of the things we discuss as epilepsy professionals is SUDEP. For those that may not know about SUDEP, it stands for Sudden Unexpected Death in Epilepsy. Some of the proposed mechanisms for this are cardiac arrhythmia, respiratory dysfunction, dysregulation of systemic or cerebral circulation during a seizure, and seizure-induced hormonal and metabolic changes during a seizure. The incidence of SUDEP is thought to be 1 death per 1,000 people with epilepsy every year. When you consider SUDEP, there are different risk factors, one of which is patients that have generalised tonic-clonic seizures, especially when these occur at night or during their sleep. Medication changes. If a medication is not being effective and we're introducing one and trying to withdraw another, if they're not taking the medication as prescribed or not taking the correct dose, alcohol or substance misuse, people with epilepsy and depression or mental health conditions, if they are pregnant, have an intellectual disability, or if they have infrequent epilepsy reviews or engagement with their epilepsy specialist. We then have to look at ways of reducing the risk of SUDEP. We encourage our patients to take their epilepsy medications as prescribed. This can be challenging, especially in our teenage population, due to rebellion, mental health struggles with living with epilepsy. And if they are vomiting, for them to know that they can repeat the dose if they vomit within 20 minutes of taking it, but they can only do this one. And if they take each anti-seizure medication separately, we recommend 30 minutes apart. However, there have been some issues with this, as if they are on 5 or more medications. As you can imagine, this can take quite a lot of time. We go through ways of them avoiding missing doses of anti-seizure medications, such as pill boxes, alarms, anything that might help. We recommend avoiding common seizure triggers, such as lack of sleep, stress, too much alcohol, and the use of recreational drugs. And our female patients, if they are of menstrual age or have menstruation that is infrequent, heavy, painful, or just if seizures occur when they are menstruating, we would ask them to consider hormonal management of these, as Sophie's discussed earlier, through the options of contraception and hormonal treatments. And we do have some safety equipment which we provide advice around. Sorry, I think I've said to go on to the next slide there. So when we look at our safety equipment, we can look at seizure monitors. Some of them are wearable monitors, which again almost look like the Fit watches, the smart watches, bed monitors, seizure alarms with video monitoring. Other monitors are baby audio monitors and baby video monitors. However, your teenage patients and your adult patients obviously are not keen on this due to independence and privacy. Unfortunately, though, some of these monitors can be rather expensive, and some do come with a monthly subscription fee. So there are charities that help provide monitors and funding towards them. The main ones are Dravet Syndrome UK, the Daisy Garland, that's specifically around MFIT bed monitors and Pulmolink SATS monitors. And there is also the John Shaw Foundation. Monitors are exempt from VAT. You can also get safety pillows, which are known as sleep-safe anti-suffocation pillows. These are highly phosphorus with an open cell structure with breathable air ducts to prevent suffocation if someone was to have a seizure during sleep. Charities providing pillows are Hub for Epilepsy, but this is for children and young people under the age of 19 only. Next slide, please. As I said before, myself and Sophie work with children with epilepsy, but we do work around when we transfer them over to adult care, because we only care for them from around age 18 to 19. So we do quite a lot of work in preparing them for adulthood and becoming more independent with looking after their epilepsy. Most areas offer an annual transition appointment from school year 9, so that's around your age 13 to 14, aiming for transition to be completed at age 18 to 19. During these transition appointments, we gradually try to build up to the child and young person with epilepsy seeing us independently for part of the clinic, hopefully leading to most of the clinic appointment. And during this time, we discuss their career choices, drugs and alcohol, driving. As I mentioned earlier, you have to be seizure-free, expectations of adult services, to try and manage the expectations as they move over, because most of them have been used to having support from their parents during appointments as well. How to make and change appointments, medication management. So this includes looking at how they can order repeat prescription, reminders for appointments, docket boxes so they don't miss doses, where to access help for mental health, reproductive health, which Sophie touched on earlier, SUDEP, reducing the risk of SUDEP, any concerns they may have around that, and that they should have an annual GP LD health check from the age of 14. Next slide, please. There are some transitional resources out there. The one we tend to use is the 10-stage transition journey from the North Cumbria A Healthier Together website, and from Together for Short Lives, which is the UK registered charity for children's palliative care. The Stepping Up transition pathway is written for professionals who work with young people with life-limiting conditions, and there's also a transition checklist for young people. Nicola Heenan, who is the paediatric epilepsy specialist nurse in Hull and the paediatric lead for ESNA, which is the Epilepsy Specialist Nurses Association, has produced some transition documents which include easy read versions, and these are going to be adopted by NHS England. We're hoping the final document will be ready in 2025, as it has just needed some final amendments. This is as there has been work around it at present, because whilst we've had easy read versions of the Ready Steady Go transition document, there hasn't been a one specifically for children who are neurodiverse or with complex epilepsy. Next slide, please. As mentioned, within the transition section, we do discuss mental health. Mental health is big on everyone's radar at the moment, and we're now going to look at the mental health and social impact of epilepsy. So epilepsy impacts upon mental health, which can come through in behaviour. This can either be because of the seizures themselves, and or some medication can cause hyperactivity, aggression and challenging behaviour as part of side effects. Learning. Children and young people with epilepsy may have problems with memory, attention, concentrating and processing information. Again, this may come from the seizures or it may come from the medication itself. Approximately 40% of children and young people with epilepsy have a coexisting mental health disorder, such as anxiety or depression. It can also affect children and young people with epilepsy in terms of their social interaction, their educational needs due to time off for appointments, days off after seizures, and days off due to side effects of medication. In addition to that, sleep can also impact upon this. Again, this could be due to medication, the seizures. These are that can disrupt sleep or make the child or young person sleepy. One of the others that we see, and from my professional experience is more so in secondary schools, is stigma and bullying. During the transition appointments and other appointments, we do try to encourage our children and young people with epilepsy to be open with their peers, families and friends with regards to their epilepsy and their seizures and how they can help. And often it is due to people not understanding that bullying occurs. And once their friends and peers know, they tend to want to support and help them. Some support services available. As we heard from Leah earlier, there's Epilepsy Action. There is an 8-week online phone counselling offer for people with epilepsy aged 18 plus. Living Well with Epilepsy, which is a 4-week group programme. There's adults with epilepsy, women only or men only. Young people with epilepsy, this is for age 18 to 30. There's parents or carers of children with young epilepsy support, family members of people with epilepsy, and there's the befriending service, which matches the person with epilepsy with a volunteer for regular phone or online chats. One other charity that is specifically aimed for children and young people is Young Epilepsy. These have online youth clubs for ages 10 to 12 or for 13 years and above. They also offer youth support services, which is a one-to-one session, or there can be group work, and these can be done virtually or in person. As epilepsy specialist nurses, we provide advice to other professionals, family support. This can be through phone, email, text, and some trusts have WhatsApp, but not all trusts. Medication, quite a lot of epilepsy specialist nurses are non-medical prescribers, and this can include deprescribing and switching medication form. We undertake nurse-led clinics for new patients, review patients and transition. We can request investigations. We do a lot of work around safeguarding, and we also provide training. Obviously, we're doing the one this evening, but we do skills and other healthcare professionals within trusts. And we also look at hospices and other care places, and this can provide safety, first aid or emergency medication. And don't forget, epilepsy specialist nurses, we usually know the answer. Within this, we have included a list of our contact details, just so you have a point of contact if you have any questions or queries. What can GPs do to help the families or to help the epilepsy healthcare professionals? What we often do is ask families to keep a seizure diary. Some parents like to make notes on their phone, and some families like to use the Epilepsy Action or Epilepsy Society or the Brain Trust's seizure diaries. We ask them to describe events, what was happening before, which side of the body was affected, or colour change. One question I often use a lot is, what is the first thing that made them aware something wasn't right? Because it usually helps provide a structure. We also look at asking them to time events with a watch or clock, ask for videos, and our general advice is for them to attend the emergency department for seizures lasting more than 5 minutes, or if they have concerns about breathing or an injury. Information available. There is first aid and safety advice from Epilepsy Action, Epilepsy Society, Healthier Together, North East NHS and Young Epilepsy. And then the final slide just shows a list of resources from Epilepsy Action, Epilepsy Society, FND Action, Healthier Together, the International League Against Epilepsy, Medicines for Children, we use these quite a lot, SUDC, SUDEP Action and Young Epilepsy. Thank you for listening. I hope that's been helpful.
Great. Thanks for that presentation, Sarah, and obviously for Sophie's prior to that. Really helpful, a huge amount of information has been imparted. Appreciate we're quite short of time now for colleagues, but just wanted to pick up on one particular item that's come into the chat here from a member of staff from HDFT, Christine Corner, in relation to the support journey that's available for those young people who are diagnosed with non-epileptic seizures or a combination of both epileptic and non-epileptic. I wonder whether or not, Sophie, you're around to be able to respond to that?
Yes, so the last slide that had the resources on, that had the website for FND Action, and that's functional neurological disorder. It's the website. It has a lot of good resources, both for professionals and for young people and their families who are having, whether they're having functional dissociative seizures alone or whether that's in combination with a diagnosis of epilepsy. In our service at Northumbria, we look after young people who have epilepsy alongside functional seizures, and we also look after young people who are going through the process of being correctly diagnosed. So I have some young people on my caseload who we're investigating them to find out whether it's epilepsy, and even when it turns out to be functional seizures as part of functional neurological disorder, we still support them for a period of time. They have health psychology, clinical psychology in our trust that will support them, and then once it's being managed better, then I would discharge them.
Super. Thank you. Hopefully that responds to that question. Do either Dr. Boardman or Sarah want to respond to anything in addition to that?
I would just like to say that the same as Sophie, we do in Newcastle also support the ones with the functional neurological dysfunction seizures, and once they're more stable, then we'll discharge them.
Excellent. Thanks, Sarah. I've also noticed that Dr. Kumar's provided a response in the chat there, so that's helpful too. Okay, there was only one point that was raised in the chat sort of at the beginning, and that was just something that you brought to the fore, Dr. Boardman, about the work that you're doing collaboratively with Epilepsy Action with regard to the primary care online offer. I don't know if you want to add anything to that to share with the group just for their information.
Yeah, it was just to point out, obviously Epilepsy Action have had this module available for a while, but it basically says on the tin it's for primary care nurses only. But in the conversation yesterday, obviously what we're trying to move towards is a training module that could be for any primary care clinician. So we'll be reviewing that with Simon Privet, who's the training lead in Epilepsy Action. And hopefully we'll try and make that as useful as possible for primary care clinicians going forward.
Great, another piece of collaborative work, fabulous. Okay, excellent. So I appreciate now technically we're out of time, so unless there's any other burning questions from individuals, all that's left for me to say is thank you so much for the participants for attending tonight and giving up their time to be part of this. Also to the clinical teams and colleagues who've supported this event in terms of the preparation and delivery. And also to advise primary care colleagues that if there are further feedback about this session or any areas that you might want additional information about, then please do let us know. You'll see there in the chat we've just put an MS form link, which is an evaluation form. So it's just asking for feedback about the session and any other feedback about any additional areas that you may wish us to provide maybe a follow-up session about. And obviously we will be making this available on our Healthier Together website. All of the resources that have been we've discussed will be made available in the form of slides, and obviously the recorded resource will be emailed to those people who have signed up and registered for this session. And we would encourage you to sort of onwardly share this with your colleagues and peers, and we look forward to potentially the future for more of these sorts of sessions to provide you with the information you need. Okay, so thank you very much, everybody. It's been an excellent use of time, and we're just out of time. But great to have you all, and thank you very much for your time. Night all.